A middle-aged, dominant, right-hand dominant female has been reviewed in the clinic. She's complaining of numbness about a couple of centimeters above the wrist crease, as well as loss of sensations around the thumb. She confirms that she has nocturnal lucidation, and her hand as well goes into sleep while in the car. It has been there for 4 to 6 weeks. She denies any cramps in the hand or any history of trauma or any palm or hypersensitivity. She needs to shake her hands at night and experience numbness and tingling sensations. As per profession, she is working as an IT technician in an organization. You move forward to examine the patient. There is a positive tendal sign directly over the palmar cutaneous branch of the median nerve, which the patient says stimulates her numbness and tingling at the level of thinner eminence. In addition, she has area of numbness 2 into 2 centimeter directly over the area of innervation of the palmar cutaneous branch of the median nerve in the palm. Further assessment shows Phelan test is positive and the tendal test to the wrist is negative. A median nerve compression test is positive, as well as Weber 2-point discrimination is greater than 1 centimeter. The patient grip strength is further assessed by the JAMR dynamometer, which is 110 on the left side and 110 on the right side as well. The pinch is 18 pounds in the left and 18 pounds on the right side. All measurements are an average of 3 trials. Radiographs are negative for the patient. EMG shows nerve conduction velocity significantly reduced for the median nerve, especially in the sensory fibers. Even to the index and the proximal conduction and other conduction velocities are normal. As per the history, a differential of carpal tunnel syndrome, neuroma, arthritis, thyroid disease, diabetes mellitus, tenosynovitis, and gout can be expected. The diagnosis here is quite simple and straightforward, and that is carpal tunnel syndrome with compression of palmar cutaneous branch of the median nerve. While talking about the carpal tunnel syndrome, it's one of the commonest conditions of the hand. Compression of the median nerve by surrounding structures cause sensory and motor disturbances. The sensory disturbance is more prevalent. Chronic repetitive stress on the carpal tunnel and the median nerve within it is most common cause of idiopathic carpal tunnel syndrome. There has been association with occupations like typing, carpentry, and those where you require wrist activities. Recent research has shown that the association is not that significant. Carpal tunnel syndrome is mostly diagnosed by just a clinical history. Common complaints include nocturnal paresthesias, heavy feeling in the hand going on to sleep. Pain may radiate to the arm or the shoulder or the neck. Patients do complain of weakness that hinders the ability to grasp things. Numbness when gripping objects is another symptom which is present. Non-operative modalities include activity modification, splintage, magnetic support wraps or injections. In the younger patients with early stages of carpal tunnel syndrome, these modalities may relieve symptoms. Anyhow, when the patient feels conservative management, a surgical intervention would be required to regain lost function. Open carpal tunnel release has been shown to relieve symptoms of median nerve compression for many years. Endoscopic carpal tunnel release has shown to reduce tissue trauma and speed the post-operative recovery. However, there is long learning curve and expensive equipment associated with the endoscopic carpal tunnel release. In our case, we proceed further for carpal tunnel decompression. The patient is shifted to the operation theatre. In the anesthesia room, a local anesthesia is used. 9 ml of 0.25 levodopa plus 1 ml of 1:200,000 adrenaline, along with a 1 ml of soda bicarb is utilized to give local anesthesia around the area. The injection can be given subcutaneously around the area of the carpal tunnel, as well as deep into the carpal tunnel itself, traversing the transverse carpal ligament. A line is drawn at the level of the thumb, about 2 cm distal to the pisiform bone, and that is called Kaplan line. Another line is drawn at the radial border of the fourth digit, and the intersection is and distal to the Kaplan line is the area where carpal tunnel and our incision will lie. A 2.5 cm incision is made parallel to the radial side of the ring finger, and 1/3 distal to and 2/3 proximal to the proximal line, extending slightly off the distal border of the thinner muscles. A regular retractor is placed in the distal aspect of the incision. The soft tissue is spread and fat is identified, which pouches up at the distal aspect of the transverse carpal ligament. The tissues are retracted until the transverse carpal ligament is reached. The tissues are retracted until distal 1/3 of the distal transverse carpal ligament can be visualized. The transverse carpal ligament is then incised for a distance of 1 cm and then extended distally till the fat is exposed. The fat is a sign that the superficial palmar arch is about to get exposed, and we stop there. The content of the carpal tunnel, including the median nerve, can now be identified, visualized, protected throughout the remaining part of the operation. A smooth, blunt pilot instrument is then placed proximally between the underside of the transverse carpal ligament and the carpal tunnel contents. The instrument is withdrawn and a palmar stripper is then placed under the ligament and into the wound under direct visualization. Sharp instrument designed to prepare a channel through the thick connecting tissue directly palmar to the ligament. A stripper is inserted into the groove that was formed distal division of the ligaments and pushed proximally until resistance is felt. The stripper is removed and a double pilot instrument is introduced. This instrument with long, dull lower and upper skids allow for full visualization of the passageway beneath the ligament. The pilot is removed and the tome guide is inserted between the undersurface of transverse carpal ligament and the carpal tunnel contents. To allow for complete division of the transverse carpal ligament, the tome guides is placed proximally. The patient wrist is fully hyperextended, the position in the neutral alignment. The cutting tome is inserted into the prepared ligament and passed proximally. The cutting tome should not be reintroduced after the proximal ligament is transected. The cutting tome is removed and the content of the carpal tunnel can be inspected now. The skin is closed and the soft dressing is applied on the palmar and the wrist. Digital range of motion and tendon gliding exercise are taught to the patient in the operating room. The patient returns in 2 weeks' time for suture removal. Complications that may occur during the surgical intervention is stiffness, nerve injury, vascular injury, infections, and incomplete release. Although complications are rare, inaccurate diagnosis may predispose the patient to complications. The patient with recurrent carpal tunnel syndrome or with destroyed anatomy due to fracture or dislocation should never undergo limited open incision carpal tunnel release. Open carpal tunnel release should be also performed in patients who have neurological deficit in the thinner muscle area and near complete loss of sensory perceptions.